Hello, my name is Stuart Gold. I'm a consultant in anaesthesia with a special interest in enhanced recovery after surgery. The purpose of the e-learning package which we've created is to try and provide generic principles and information about enhanced recovery. So they're not specific to any individual trust or any surgical specialty, elective or emergency group, but it's to broadly explain and try and give you an understanding of the principles behind enhanced recovery after major surgery. By way of an introduction, what I'd like to talk about is what enhanced recovery can mean for different patients. There's a continuum of enhanced recovery as applies to different patients in different specialties with different conditions, whether they're elective, whether they're emergency. One extreme would be the elective orthopaedic patient having hip replacement who is able to follow a fairly prescribed and didactic programme of preoperative information, preoperative interventions such as pre-op drinks, and making sure the patient's encouraged to eat and drink as long as they can up to surgery. They follow a very specific surgical and anaesthetic plan to standardise their care, and they then follow a very standardised physiotherapy programme post-operatively. And these patients, assuming that everything goes smoothly for them, can be fairly predictable, and what happens to them on any individual day can be predicted with a reasonable amount of certainty. The other end of the spectrum would be an emergency surgical patient who is having an operation which is unplanned. They have less opportunity for information preoperatively, and their post-operative course will be more complicated and more difficult. That patient can still undergo the principles of enhanced recovery, and that means making sure the patient is as informed about what's happening to them and what the likely course is going to be as possible, but also that if they are allowed to eat and drink, that they're encouraged to do so. If they can mobilise at all, that they're encouraged to do so, albeit they may only be able to sit out of bed for the first few days after an emergency operation, instead of, we would hope, an elective patient could walk around in the first day or two after their operation. But the principles are broadly the same, which is if they can eat and drink, they should. If they can mobilise either into the chair or go for walks with supervision, then that's what they should do. Discharge planning is also important and should take place in conjunction with the patient, and should take into account their confidence and what they understand about how they're likely to recover from their